Hello, class. Welcome back to BUS80, Medical Terminology and Anatomy. And today we're going to cover Chapter 8, the gastrointestinal system. So let's get right into it. So good diagram, but we're going to go ahead and start talking about many of these pieces. In particular, starting at the top, the alimentary canal, which comprises, the mouth and the pharynx, the esophagus, going down into the stomach, and then the accessory organs, the liver, the gallbladder, the biliary ducts, the pancreas. Okay, so the major components of the alimentary tract, which is the GI tract, the gastrointestinal tract, mouth, pharynx, esophagus, stomach, intestines, rectum, anus. All right, so we're going to go all the way through all of these different components. All right, two major functions of the alimentary canal is digestion and elimination. Okay, so digestion, breaking down different food to be absorbed and utilized appropriately, and then elimination is where we get rid of any unused waste products. Okay, so the alimentary canal starts with the mouth. The GI tract starts with the mouth. So the lips, the teeth, the cheeks, everything that's involved in mastication or chewing, that's where the alimentary canal begins, which includes the salivary glands as well. The pharynx, which is the cavity or the tube that propels food to the esophagus. Okay, and then the esophagus, I like in the third bullet, the site of peristalsis. And peristalsis is this rhythmic contraction in the esophagus that pulls food down to the stomach. Okay, so that's called peristalsis. All right, and then the stomach, which is the temporary storage place for food, and then that's where it kind of mixes with gastric secretions to help break things down. Okay, so let's see. Intestines, the small intestine and the large intestine. The thing that I like that's kind of a misnomer about the small intestine is that it's small, and it's not. It's about 20 feet long. Okay, so the small intestine is fairly sizable. All right. There's three major divisions: the duodenum, the jejunum, and the ileum. Now, I always remember that as DJI, duodenum, jejunum, ileum. And I'm going to tell you that there's two ileums that you need to be concerned about. This particular one in the small intestine, ILEUM. The way I remember the two, to keep them straight, is ileum versus ileum, ILIUM. That ileum is in the hip, okay? And the way I remember that is whenever I see those words printed, the way I remember it is ileum, ILIUM, hip. Hip has an I in it. So if I see ileum with an I, then I know we're talking about the hip. Ileum with an E is referring to the lower portion of the small intestine. So if you can remember DJI, duodenum, which is at the top of the small intestine, the middle portion is the jejunum, and then the bottom portion, or the most inferior portion, is the ileum with an E. Okay. Then the large intestine. The large intestine has 6 different segments, and there's actually, I know in your text they have a good abbreviation or acronym for how to remember those 6 segments. It's not going to be on your exam, the 6 segments, or having to put them in order. But a good way to remember that, just like DJI for the small intestine, the lower portion of the intestines, the large intestine, those 6 segments, your book says cat desire. if you can remember that, you'll be able to define those 6 segments in order. Okay, so if you think of CAT, cecum, ascending colon, okay, and then the transverse colon, which goes across. So ascending is going down, transverse is going across. Okay, so the cecum, the ascending colon, the transverse colon. And then they say desire, DESIRE. The DE is descending colon, okay? And then, sorry, I said ascending. Ascending colon is going up. Descending colon is going down. I apologize. The descending colon is the DE, okay? The SI is the sigmoid colon. And sigmoid colon, I always kind of try to remember that if I'm looking at a diagram, and I had to diagram the large intestine, the sigmoid colon is kind of in an S shape. So sigmoid and S shape go together. Okay, so DE for descending colon, SI for sigmoid colon, and then RE for rectum, and that gives you that acronym CAT desire. Okay, so CAT, cecum, ascending colon, transverse colon, descending colon, sigmoid colon, sigmoid, and then the rectum. Okay. Layers of the GI tract, because the GI tract does have inner and outer layers. The inner layers are the mucosa, and then the outer layers are the visceral and the parietal peritoneum. Okay, so the visceral peritoneum covers the organs, and then the parietal peritoneum lines the abdominal cavity. Okay, major structures and functions of the accessory organs. Okay, so the accessory organs, the liver, which is what? It's the largest organ in the human body, okay, is the liver. The liver has this amazing ability to kind of be beaten up. We can really do a lot of damage to the liver, and oftentimes it can kind of regenerate itself and respond favorably to being punished. Over the course of time, that may not work. You know, the longer. So when we think of something like somebody who is an alcoholic, they can beat their liver up pretty intensely with alcohol. However, the liver can continually just respond to it and potentially even become kind of used to it. But over time, you know, really just repeated beating it up, at some point the liver's going to argue and say, you know what, I've had enough, and could really create some problems long term, you know, life shortening type problems. But I kind of like to throw that out there. We beat up our liver fairly frequently with the things that we ingest and the things that we eat and drink, and the liver has this amazing ability to kind of bounce back often. Okay, so we have the liver, the biliary duct, and the pancreas. Okay, and the liver and the pancreas are very interconnected. And then what do those things do? That it contributes hormones, it releases enzymes to help break down fats and triglycerides. Okay, let's see, and then the gallbladder. The gallbladder stores and concentrates bile, and bile helps to break down fats and neutralize gastric secretions. The other thing that bile does is it helps to prevent jaundice. Okay, so one of the common signs of liver disease or pancreas disease can be jaundice, yellowing of the nails, the whites of the eyes. That's usually a great indicator of liver or pancreas problems. Okay, so that means that that bile is not working appropriately to help break down these products. Okay. Let's see. And then the pancreas, 2 types of cells, endocrine and exocrine. The endocrine cells secrete hormones into the blood, and then the exocrine cells secrete digestive enzymes, okay, to help break down things like fats. Okay, physical exam terms, anorexia, loss of appetite, auscultation, that sense of hearing. Typically we auscultate GI sounds, gastrointestinal sounds, with a stethoscope, okay? So a doctor can put a stethoscope on you to actually listen to the sounds of your bowels, okay? Bowel sounds, borborygmi is growling, stomach growling. Typically we just say stomach growling, right? And then there's a couple of different, hyperactive, rapid, high-pitched gurgling. If you have something like maybe irritable bowel syndrome, you may have fairly frequent growling sounds, right? And then hypoactive sounds occur less than 1 minute, less than one per minute. Okay. Other things, cachexia, ill health. It really is a general feeling of just feeling really, really kind of not good. Okay. And I think how does your book define it? It says a profound state of overall ill health and malnutrition, characterized by weakness and emaciation, which is pretty much just wasting away. Okay, we know what diarrhea is. Dyspepsia is kind of a, I would call it something of a generic term to define just general abdominal discomfort. Okay. Dysphagia, two different types of dysphagia, just like ileum. Dysphagia, AGI, is difficulty swallowing. Dysphagia, SIA, so you have GIA, difficulty swallowing. SIA is difficulty speaking. Okay. And the way I remember that is I just remember if I see dysphagia, and I see it with SIA at the end, speaking, S, okay? So I put those together. That's how I keep those things straight. Another way you could do it is if you look at dysphagia with a G, you could say gastro, difficulty swallowing, to kind of keep those two dysphasias separate whenever you see those terms, okay? Heartburn, burning sensation in the esophagus. We have gastroesophageal reflux disease, which we commonly call GERD, G-E-R-D. That's kind of a fancy term potentially for heartburn with that acid reflux. Okay. Hematochezia, the passing of bright red blood in stool, hematochezia. Okay. What else? We've gotten jaundice before, nausea. Occult blood, very small amounts of blood that have to be microscopically examined. We do occult blood stool tests. Oftentimes, we call that a hemoccult. And a hemoccult, if you've ever seen one in an office, where we do a rectal exam, and then there's these hemoccult cards that we'll do a rectal exam and then smear on the cards, and then put a little developer fluid on the card and see if that lights up, showing us this occult blood, which we can't see, but is actually in the stool or in the rectum. This could be an early sign, possibly, of colon polyps or colon cancer. So we do that as a screening test for colon cancer. It doesn't necessarily mean that somebody's got cancer, but it's an early indicator, which would typically prompt us, if we had occult blood in the stool, that would prompt us to probably do, or your provider to do, a colonoscopy so that we could take a deeper look inside the colon and see what's going on. Okay. All right, a couple other terms. Polyphagia, consuming abnormally large amounts of food. That's a good one. Polydipsia. Polydipsia is excessive thirst. Okay, so that would be a diagnosis that we might use for somebody maybe before we've diagnosed somebody with diabetes. If they came in and said, hey, I'm having, chronic thirst and excessive urination, so they're having polydipsia and polyuria. That may be the initial diagnosis for what brought somebody in. And then upon, probably blood work, then we would make a later diagnosis potentially of diabetes. These are the terms that we would use for those particular visits that prompt that patient to come in for those things. If you came in for excessive thirst, I don't know why I'm always thirsty all the time. Polydipsia is the diagnosis today for that visit, okay? We may be changing that diagnosis for future visits, right, upon doing testing and that type of stuff. Okay, let's see. Different blood tests. We do a fair amount of blood tests for GI-related issues. Probably these are typically the most common. Alkaline phosphatase, or an ALK phos, measures enzymes found in the intestines and the biliary system. Helicobacter pylori, or H. pylori, it says, which is seen in gastritis or inflammation of the stomach and duodenal ulcers. This is a good one. We can typically treat H. pylori with antibiotics. If we were to find that, we can also do H. pylori tests as part of a stool sample. So not just in blood, but we could check that as part of a stool sample as well. The amylase and lipase, these are two tests that we use oftentimes to measure pancreas health. Okay, so if there's any significant damage to the pancreas, elevated amylase and lipase enzymes will tell us that there's some significance or significant damage or illness with the pancreas. Okay, and then total cholesterol, measures the cholesterol that's circulating through our bloodstream. Okay, just like virtually everything, we have a variety of different diagnostic imaging tests, CT scans, MRIs. Then we get into things like the barium exams, okay, where we use a contrast media, where we may have somebody swallow or inject the barium, like in an IV, to light up certain structures within the GI tract. Okay, so that's very common. CT scans, endoscopes, endoscopy is very common, to look like at the pancreatic ducts, to really get into the innermost workings of the GI system. These are some of the things that we might do. Liver and spleen scans, okay, MRIs, to look at underlying structures. Okay, let's see, ultrasounds, yep. Okay, upper GI and small bowel things, colonoscopy, I think we've got that, yeah, colonoscopy, for a good overall examination of the colon. Flexible sigmoid oscopies, or flex sigs, take a look at the small intestine, I do believe, for flex sigs, fecal lipids tests, gastric emptying study, laparoscopies. I mean, all kinds of different tests that we do for the GI system, which is actually really good because we can have early diagnosis of problems with the GI tract. Okay, stool culture is very common. We do them, in particular in family practice. We do stool cultures all the time. As gross as it sounds to do stool cultures, stool and urine, the way we excrete wastes, stool and urine, actually both of those things tell us a lot about what's going on with numerous different body systems. Okay, so stool cultures tell us a lot about what's going on with through the alimentary tract, through the small intestine, the large intestine, the liver. Stool tests will tell us a lot about what's going on with the stomach related stuff. Urine tests give us a lot of information about some about the liver as well, and the kidneys. So these are two things that, as gross as they may sound, offer providers a huge amount of information without having to really do any real invasive stuff, right? A patient simply provides a stool sample or a urine sample, and we can tell a lot about what's going on, okay? Let's see, some disorders of the mouth and the esophagus. Very common, erythroplakia, lesions of the oral mucosa, erythro being red, so they'd be red lesions. Leukoplakia would be white lesions, white spots in the back of the throat. That would be possibly leukoplakia, because leuk, L-E-U-K, is white. Gingivitis, inflammation of the gums. GERD, gastroesophageal reflux disease, is that kind of fancy term for heartburn. Pyrosis is also heartburn. Pyrosis, P-Y-R-O-S-I-S. I always say pyre equals fire. P-Y-R equals fire. Heartburn. Pyrosis. Okay. So if you can remember that, I don't know if that helps at all. Let's see, what else do we have? Hiatal hernia. That one is fairly frequent, that we see fairly frequently. Stomach protrudes through a structural defect in the diaphragm. This could cause some different issues for people. Very common. Stomatitis, mouth inflammation. Oh, there was leukoplakia there, white patches on the oral mucosa. So you had erythroplakia and leukoplakia. Okay. Let's see, ascites is very common, accumulation of fluid in the peritoneal cavity. We do see that one fairly frequently, and would have to release that fluid maybe through some kind of a shunt or something. Celiac disease and intolerance to gluten, which has become much more prevalent over the recent years. Gluten hypersensitivities and celiac disease. Crohn's disease is a chronic inflammatory bowel disease. Gastroenteritis, inflammation of the stomach and the intestines, can create chronic pain or acute bouts of stomach pain. Okay. Let's see, what else? I'll let you guys read your book on some of those. Irritable bowel syndrome, of course, many people suffer from that, which is usually diarrhea with these intermittent bouts of constipation, okay? For most people, figuring out what triggers cause their irritable bowel system is usually the best way, the best way to counteract having irritable bowel syndrome. Of course, lactose intolerance, we know that's a person's inability to really, what would we say, not metabolize, but be able to consume dairy products. Okay. Ulcerative colitis, another one, chronic inflammatory disease that affects the mucosa of the colon. Very common, can be very painful, cause significant lower abdominal pain or stomach type pain. Okay, disorders of the anus and the rectum, anal fissures, very common, laceration of the lining of the anus. We'll see anal fissures with people that are suffering from constipation and having difficult bowel movements. May develop anal fissures from trying to push stool out. That can be difficult and painful, and can cause tears in the lining of the anus. Okay, hemorrhoids. It says varicosities of rectal veins. That's when those varicosities fill with blood, and often hemorrhoids are painful. They can be caused by chronic constipation. That chronic pushing and putting that pressure on your rectum to release wastes can cause these varices to fill with blood. They can be very painful. They can be internal hemorrhoids on the inside of the anus, or they can be external hemorrhoids on the outside. If they're external, I've been involved with providers that lance external hemorrhoids and drain them of the blood. to provide relief for the patient. That's another one of those things where you usually get instant gratification from a patient right away when they come into the office and maybe they're having difficulty walking because their bum hurts as bad as it does with an external hemorrhoid. When they leave after we've lanced it and drained it of blood, oftentimes patients feel so much better when they walk out, and then we get that instant gratification of thank you so much for helping me. Again, I think I mentioned it last week. We don't get that a lot. We just don't get instant gratification oftentimes in the doctor's office. Usually people will walk away and take their prescription or go see a specialist and get their problems taken care of that way. And then we don't really hear from them that, hey, this really worked, or it's just one of those weird things. So ear lavage, removing earwax, always instant gratification, and then lancing hemorrhoids typically gives you that too, as a medical assistant or as somebody who works with patients in this realm. Okay, let's see what else. Appendicitis, disorders of the accessory organs, appendicitis, inflammation of the appendix. Most of you guys know that a ruptured appendix is very bad. Worst case scenario, you could potentially expire from an appendicitis or a ruptured appendix. Very easily treatable, caught early, which is typically just removal of the appendix, just like cholecystitis or inflammation of the gallbladder. Same thing, we typically, for chronic problems or for severe pain, remove the gallbladder, and then we relieve that problem for a patient. An appendicitis, though, is a little bit harder to diagnose sometimes in females because a lot of the symptoms can mimic things like ovarian cysts. Okay, a lot of the symptoms that a woman might have with ovarian cyst may mimic itself to being the same type of pain and stuff that you would get with an appendicitis. So that's why it's important to get a film of the appendix to actually see if it's inflamed or not. Okay? Cirrhosis of the liver, chronic, degenerative over time. This would be the worry we would have with alcoholics or chronic alcoholics. Chronic alcoholism is that they would develop cirrhosis, which is basically like a hardening of the liver or destruction of the liver. Okay. Hepatitis, inflammation of the liver. So hepat is liver, itis, inflammation. Two types of hepatitis, viral and non-viral hepatitis. We have different types, A, B, C, D, E, G. Hepatitis A is oral fecal hepatitis. That's how we contract it. So it's not a bloodborne pathogen. I think it's technically considered a bloodborne pathogen, but it's contracted through oral fecal, unclean sanitary conditions. We oftentimes see outbreaks of hepatitis A from restaurants, from unsanitary conditions. Okay, people that don't wash their hands after they've used the bathroom, that type of thing. We do have vaccines for hepatitis A and hepatitis B. We don't have, probably our next common hepatitis that we see is hepatitis C. We do not have a vaccine for hepatitis C. So A and B we do have vaccines for. If you are going into healthcare, you definitely will receive or should receive hepatitis B vaccine. That's probably our most common bloodborne pathogen that we could come into contact with when we're working with patients is hepatitis B. Hepatitis A vaccine is oftentimes considered a travel vaccine. So when somebody's traveling maybe to a third world country, or you're going to someplace to go on a safari and you're going to be out in the wild, away from sanitary conditions, we would oftentimes recommend that you get a hepatitis A vaccine for those conditions. Okay, let's see. Pancreatitis, out of these disorders, probably the most common that I have seen personally, inflammation of the pancreas. Again, this is one of those things where oftentimes patients have to figure out what triggers their pancreatitis. It oftentimes is related to food products that can cause acute bouts of pancreatitis. Most people that have been diagnosed with pancreatitis, they have chronic pancreatitis, so they always have it, but there are things that can really make it go crazy, and that would be then acute pancreatitis. So this is one of those instances where you can have a chronic condition, but also have acute flare-ups of that condition. Okay. Different treatments, gastric lavage. Lavage means irrigation. So if you ever see that, like ear lavage, gastric lavage, that's irrigation. Okay. A gavage is a feeding tube. Nasogastric intubation, inserting a tube into the stomach through the nose. That could be for feeding, for maintaining caloric intake, or for instilling medicine directly into the stomach by using a nasogastric tube. Okay. A couple of other things here. The esophagogastrostomy, removal of part of the esophagus. Esophagojejunostomy is connecting the jejunum, which was, if you remember, the top part of the small intestine to the esophagus. A couple different surgical procedures. Esophagectomy is a removal of part of the esophagus. Gastrostomy, if you remember last week, I believe we talked about the difference between ostomy and an otomy. Ostomy typically is a permanent opening. So a gastrostomy would be creating an opening in the stomach to place a feeding tube, which may be there for long term. Total gastrectomy, removal of the entire stomach. We do that periodically, in particular for something as serious as like maybe stomach cancer. Okay. Different surgeries, resections, colectomy and excision of part of the colon, removing part of the colon. Again, that might be for something severe like chronic polyps in a certain part of the colon or colon cancer. Okay. Ileostomy, creating an opening between the ileum and the abdominal wall. Okay. Liver surgery, lobectomies, removal of part of the liver, again for serious chronic cirrhosis or liver cancer. We may want to remove that sick part of the liver. Okay. Let's see, and we already talked about appendectomies. Cholecystectomy is the removal of the gallbladder. Okay, so a couple of different things there. So hopefully I got through that fairly quickly. I'm trying to shorten these up a little bit because I realize that they have been running a little bit longer than I would like. So that is the end of Chapter 8, the gastrointestinal system, and I look forward to seeing you next week for Chapter 9.